Moving towards the first session directly, diabetes have threatened mankind in such a way that we can say that patients with diabetes are on higher risk of stroke. But the stroke in diabetes, is it any difference in it? To learn about this, we have our speaker with us, Dr. U.P. Sharma, renowned consultant neurologist attached to Omni Hospital, Hyderabad. And as a chairperson, we have Dr. S.K. Somani, one of the senior most neurologist and founder member of HDS, and Dr. Orindam Dash. He is another eminent neurologist attached to Narayana Hospital, Howrah. Please, both the chairperson, take your seat and introduce our speaker.
So, good morning to all of you. Without wasting much time, I will request Dr. U.P. Sharma to kindly start his session. Thank you.
All type of stroke, whether it is hemorrhagic stroke, whether it is a large vessel, small vessel, all type of stroke increases due to diabetes. So diabetes is a very important risk factor for stroke, and it increases both ischemic and hemorrhagic, all type of stroke. One more important thing is that posterior circulation stroke is commonly seen in diabetes. And stroke carries more severe outcome, morbidity and mortality if the patient is having diabetic rather than who are non-diabetic. And you see there are so many studies. You cannot see the slides, but there are so many studies which has established the relation between diabetes and stroke. So there are big studies, that is inter-stroke study. They have seen 10 big factors for the stroke. So among them, the diabetes is 8th. It's not a first. First is hypertension. But problem is that all other risk factor is having decreasing trend, whereas diabetes is having increasing trend. That is the biggest problem. So although the diabetes is in the lower side as a major risk factor, but there is an increasing trend. And stroke further increases if diabetes is associated with other risk factors. Suppose diabetes is associated with hypertension, diabetes is stroke associated with dyslipidemia, so that risk is further amplified. So if you see, there are almost associated with 10% of newly diagnosed patients of diabetes will have a stroke. Absolute risk of stroke is higher in older patient versus younger patient. That is absolute risk. But if you remember and see the younger stroke patient, in them diabetes is more common. Now there are a lot of studies, like one meta-study showing 64 cohort study, and they have pulled the data and they have shown that in women with stroke, the chances, diabetes patient has more chance of getting stroke if they are women. So women patients have more chance of getting stroke if the patient is having diabetes rather than male. That is one sexual difference with stroke risk. Pre-diabetic is also having increased risk of stroke, and pre-diabetic risk is basically, there are so many studies. The pre-diabetic definition is more important. Like some study has shown 100 to 125 milligram FBS. In that, they have not shown any increased incidence. But when the definition was 110 by 120 milligram of FBS, then stroke risk was increased. Similarly, with the impaired glucose tolerance test as well. Now, coming to the hyperglycemia and stroke, acute stroke. If you see the stroke patient, the acute stroke patient, almost 40 to 50% has diabetes. And among them, 20% have hyperglycemia without any history of prior diabetes. So a lot of stroke patients, where they presented, first time you diagnose the diabetes, the first, almost 20%. So overall, almost 60 to 70% of patients with acute stroke have hyperglycemia. And hyperglycemia leads to lesser salvage of mismatched tissue. So penumbra size will decrease if the patient is having hypoglycemia. So during this hyperglycemia, so in these cases, the chances of morbidity and mortality of stroke increases. So now, if you see why there is this type of problem, why the diabetes causes more morbidity and mortality in stroke, and you see these are all related. These are all component of metabolic syndromes, like diabetes, hypertension, obesity. All these things leads to inflammation, endothelial dysfunction, and endothelial dysfunction causes a lot of plaque formation as well as plaque rupture. So all these things, there are complicated things like lot of cytokinins are released, which causes this type of damage to the endothelium. Endothelium invites platelets aggregation, plaque formation, and plaque formation itself causes rupture due to a lot of cytokinins. So they are all interrelated. Along with that, not only endothelium, even it can affect the cardiac also, and that can lead to cardioembolic stroke. So they are all related. And as you see, the major contributing factor is due to formation of advanced glycosylated end products. And that is main cause for endothelial dysfunction, and that leads to lot of cycle like NO synthesis will be reduced. Once the NO synthesis will reduce, definitely vasodilatation property will reduce, and that causes lot of ischemic changes. And there are lot of other factors also. If you see in diabetes, even the chances of atrial fibrillation also increases, and that is one of the common cause for cardioembolic stroke. So they are all related. Now, that is one thing. One thing is that in any patient of diabetes, you should examine for the chances of stroke. Then some basic test is very important along with the blood sugar estimation. Proteinuria, high systolic blood pressure, high diastolic blood pressure, HbA1c, fasting, hyperuricemia, age, all these things predicts the increased chances of stroke. Now, one thing is very important, and this is everybody must have seen, that if any patients come with acute hemibalismus or acute hemichoria, suspect diabetes is as a etiology for stroke, because that hyperglycemia can cause this type of acute presentation, like acute hemichoria, acute hemibalismus. And if you see the CT scan, you can get in basal ganglia region hyperdense lesion. So this is very unique about diabetic associated with stroke. You will not get in any other etiology this type of clinical picture as well as this CT scan imaging. Now, coming to the management of hyperglycemia during acute stroke. As you know, there are a lot of studies, and we try to reduce the sugar as soon as possible during acute stroke, but lot of studies have done, and the inference of studies is that very intensive sugar control is not important in acute stroke, because they have shown that if you do very intensive blood sugar control, that causes hypoglycemia, and that can worsen that stroke outcome. So then we need to keep the sugar around below 200. Ideally, one should keep 140 to 180. So no need to do very intensive blood sugar control during acute period. I am talking about acute period, because studies have shown we expect that acute intensive control should get better outcome, but that has not possible in these studies. So that was the one thing. Now, once the acute phase is over, now you want to prevent the stroke. So now you want to prevent the recurrence of stroke. In that case, definitely you want to control the hyperglycemia after discharging. So in that case, you know, you have now so many drugs available, but only few group of drug has positive outcome to prevent the occurrence of new stroke. So those are the only two groups. Some groups are neutral, and some group doesn't work well. So if you see, almost 23 to 70% of acute stroke patients will have hyperglycemia and receive insulin in earlier stage. So you need to keep that target of sugar 140 to 180. Now, this is 140 to 80. Close monitoring should be done. And for patient being considered IV thrombolysis, blood sugar should be between, basically now for IV therapy, we just see the CT scan and sugar. No need for doing all these things. If the sugar is okay, CT scan doesn't show any hemorrhage, we can go for thrombolysis until there is very serious other complication, because that saves a lot of time. Now, sugar control in post-stroke period, as you say, there are almost 90% chances of getting recurrence. So we need to control the sugar very well, and we have to keep hemoglobin HbA1c below 7. And there are only two group of drug which has positive outcome to prevent the stroke. One group among is a new drug, GLP-1 agonist drug. This is a very expensive drug, but semaglutide has shown that it causes decreased incidence of recurrence of the stroke. So that is one group of drug. Although now people are utilizing this, because this is also using as a weight reduction medicine as well right now. So this is one group of drug, but it's very expensive drug, given injectable weekly doses. So diabetologists know better, but this is one drug which has got positive benefit on recurrence of the stroke. Other drug among this group is your pioglitazone. So these two drugs has only shown that this causes recurrence of the stroke. So far stroke is concerned. Gliptin, SGL2, 4 inhibitors, that has neutral. That doesn't increases or decreases. And there are so many studies So for this, only you should remember other drugs causes neutral effect, but these two groups, GLP-1 receptor agonist and pioglitazone, is most promising in prevention of secondary stroke. Once the stroke is there, then if you want to prevent that stroke, then you should select these two group of drugs. Only with pioglitazone is a problem that it causes, again, pedal edema, obesity, and other things. So that's why it is not commonly used. Although it is shown that it has got better prevention chance of getting new stroke. And you know that everything is targeted now due to insulin resistance, so I'm not going to go into detail. Everybody knows that, especially this audience. So just to summarize, these SG12 glyphosate are all neutral. This will not increases or decreases the recurrence of stroke. So now I will conclude. Diabetes and pre-diabetic are most important risk factor for all type of stroke, predominantly ischemic stroke. Predominantly if the patient is having posterior circulation stroke. Pathophysiology of stroke is mainly endothelial damage due to several mechanisms. Majority of patients with acute stroke have hyperglycemia. In acute stroke setting, keep sugar 140 to 180 range. Aggressive treatment is not useful. That has shown so many studies. For prevention, as a chronic treatment, you have to keep glycosylated hemoglobin below 7. GLP-1 agonist and pioglitazone are most effective in preventing stroke recurrence. SGL2 receptor blocker are also effective in reducing cardiovascular morbidity, but it is not stroke specific. Other risk factors like hypertension, smoking, inactivity, dyslipidemia, lifestyle modification, dietary factor, all are very important. So not only control of diabetes is important to control the stroke, you have to take into account of all these risk factors, because those things all contribute to the occurrence of more recurrence of stroke. So that is what I want to tell the audience. Thank you. I think I was in time. Thank you. Is any question regarding my topic?
Okay. Thank you, Dr. Sharma, for such a lucid presentation. In one of your slides about hemibellismus hemichoria, you have shown hyperdensity in the left-sided caudate nucleus and putamen. What is or are the causes of that hyperdensity, and how to distinguish it from hematoma or hemorrhage?
This is its value is different. Hansen value is different for hemorrhage and calcification and this type of this hyperdensity. So it is different.
Any other features from that scan can we pick up? You have shown very good scan. From the scan itself, can we distinguish between
Affected mainly the basal ganglia.
caudate nucleus putamen? Okay, and putamen is one of the commonest site of ICH bleed also.
Yes,
So how to differentiate it?
So I think it's mainly clinical.
If we don't have clinical finding, only your CT scan is there, then can we distinguish?
Hansen value. With the Hansen value we can.
Number one. Any other point? Another point is that absence of edema and absence of involvement of internal capsule, they favor the hyperdensity due to hemibellismus hemichoria. Involvement of internal capsule will go in favor of bleed. Number one. Number two is that we do use a lot of antiplatelets.
Microphone पे
Antiplatelets, but it is common knowledge that say clopidogrel, etc. we are using, but the platelet count remains same it is not decreased, but it's still the patient is benefited. Is there any explanation for that paradox?
एडिजिबिलिटी कम हो जाएगा. It's not different.
Thrombasthenia.
SGLT2 inhibitors have been shown to reduce the incidence as well as prevalence of atrial fibrillation, but you said stroke reduction is not proven. Yeah, because it does reduces atrial fibrillation. That's number one. Yeah. And the second, regarding the recent reports of semaglutide causing suicide increase, self-harming, your comment, because this is the neurology related.
সিবুট্রামিন আর ওই যে যেটা ছিল রিমোনাভেন্ট In an empagliflozin study, the EMPA-REG outcome, it was shown that the stroke is actually increased. So that is why the SGLT inhibitor is not a very good option as far as reduction of the stroke is concerned. So you're very right. You have said it very rightly.
Dr. Pandey, one reason maybe why it is neutral, because he at the beginning said one thing very important to remember, that equal 25 etiologies of percent etiologies of stroke, cardioembolic, hemorrhagic, then artery to artery emboli and micro. So probably artery to artery, maybe if there is a borderline hemodynamic, you can have more artery to artery stroke.
Well, Dr. Bansali wants to say something or ask something.
IRIS trial, where do you put pioglitazone in preventing re-stroke rate if there is no contraindication to it?
In case of diabetics, other things.
Because it was used 45 milligram per day, 30 to 45 milligram, and that too in non-diabetic subject in IRIS trial.
No, if there is lean diabetic and there is no cardiac issue, no overweight and other things, then you can use pioglitazone.
Thank you, speaker. It's time to felicitate our speaker. I would like to request our chairperson to please felicitate.